Yeah. Good evening, everyone. This is Dr. Sowjanya, your surgery educator from the platform Medicoz Community. So, today we are here to discuss the clinical questions which are highly important for your next PG preparation from the subject general surgery. So, let me give you a brief introduction about the courses we are offering from the Medicoz Community. So, first of all, am I clearly audible and visible to every one of you? Just let me know through the chat box. Yeah, if it is clear, I'll proceed further. Okay, let me know in the chat box. Just give me a thumbs up. Yeah, hoping everything is going well. Yeah. So, Medicoz Community, we are offering an early bird offer which is running for the next 24 preparation. So, you can avail the courses for the preclinical and clinical subjects as well, as we are hosting many clinical sessions as well. So, you can avail this early bird offer from the Medicoz Community website. So, you can go to the website and see the plans there and avail the early bird offer. So this probably, as the pattern is changing and all, you need to adapt to that pattern and prepare for that as well. So we will guide you through that. We'll adapt you to the pattern and help you understand the concepts easily and clear everything. So don't miss to avail this opportunity. Go to the Medicoz Community website and avail the early bird offer. Okay, so if everything is clear, shall we proceed to the questions part? Yeah, just let me know. Okay. So, yeah, first let us go to the first question. Okay. A 45-year-old female comes to the OPD with the complaints of lump and pain in the left loin. The complaints are lump and pain in the left loin. Okay. On examination, there is a firm mass in the left lumbar region and mild tenderness is present. The lab investigation show microcytic hematuria. History of loss of weight and appetite. CECT shows renal cell carcinoma. All are true regarding this except. What is he asking? Which is the false statement? Don't forget to see this except. So let's go through the question once again. What are the complaints? The complaints are lump and pain. Lump and pain in the left loin region. The loin region is nothing but where your kidney is. So probably it might be a renal mass. On examination, there is a firm mass in the, he also gave it again in the left lumbar region and mild tenderness is also present. The lab investigation shows what? Microcytic hematuria. Hematuria is indicating that it is also a renal condition. So history of loss of weight and appetite is also mentioned. So loss of weight and appetite indicates what? It might probably be a malignant condition. It may probably be a malignant condition. Yeah, after that what has he given? CECT. CECT shows renal cell carcinoma. So we need not worry to diagnose this condition. He has already given it as an RCC. So what is he asking? He is asking the false statement. So let's go through the options. Option A, most common site of metastasis is to lungs. What is he saying? The most common site of metastasis is to lungs. So where does this renal cell carcinoma metastasize to? So first of all, what is the route of metastasis? It metastasizes through the blood spread, which is nothing but the hematogenous route of metastasis. So where does these mets go to? They commonly go to the lungs. In the lungs, they are known as cannonball metastasis. Like these look like these giant metastatic lesions. So they are called as cannonball metastasis. I'll also show you the picture of this. Don't worry. Okay, so this option is correct. So this is not our answer. He asked except, no? So let's go to the next option. Option B, biopsy is the investigation of choice. The investigation of choice is not a biopsy because like sometimes post nephrectomy biopsy is sent, but this is not the investigation of choice. You need to remember this investigation of choice. What is the first investigation to be done? Like that they'll ask questions. So as given, the CECT, this triple phase CECT is the investigation of choice for renal cell carcinoma. So the investigation of choice is triple phase CECT. Yeah, so this is also not an option. This is the wrong. He's asking the false only. So this is our answer. But let's also check the other options as well. Sometimes we might go wrong. So what is the third option? Left-sided varicocele is more common than the right side. He's saying left-sided varicocele is common than the right-sided varicocele. So here we need to know a concept, that is, see, we have an IVC from which we're getting the renal veins. So the left renal vein is long. This is the left and this is right. Now you remember it as L for long, L for left. So left renal vein is long. So the left testicular artery arises directly from the left renal vein. So left testicular vein arises from the left renal vein. So this goes to the testis. So when there is any lesion in the kidney and it is compressing or encroaching this renal vein, it compresses the testicular vein. So the venous blood can't be taken up above and there is congestion of the pampiniform plexus here. So this leads to a varicocele. So we are covering a varicocele question also here. So this left-sided varicocele is more common than right-sided varicocele, as from the right side the testicular vein is directly arising from the IVC, because this is a shorter one, because the IVC stays to the right and aorta is to the left. So left is long, so testicular vein arises directly from the left renal vein. So you need to remember this concept for that. Okay. So left-sided varicocele is more common than the right side. This is also a correct statement. Now let's go with the fourth option. Osteoblastic type of bony mets are seen. So for bony metastasis there are two types, osteoblastic and osteolytic lesions. Osteoblastic means he gives us like these white opacifications, and osteolytic he will give us a cystic blackish cystic like lesions. So osteoblastic mets are seen in carcinoma prostate. Yeah, osteoblastic mets are seen in carcinoma prostate. And where are these osteolytic metastases seen? These are seen in our renal cell carcinoma and also in the papillary type of thyroid carcinoma. So this is also another important question, mark this as well. So this is also osteoblastic are seen in, okay, actually this is also a wrong statement. Fine, leave it. This is also a wrong statement. We need to have osteolytic metastasis. So here we have two options. So this is also a wrong statement and this is also a wrong statement. So these two are the answers. So let's take it as a multiple option question. Okay, let's see more about the renal cell carcinoma. Just let me erase this for you. Okay, we'll learn something more about renal cell carcinoma. Okay, so renal cell carcinoma is commonly associated with Van Hippel-Lindau syndrome. This is on the chromosome number 3. This chromosome number is also important, sometimes asked. And this has a triad known as too late triad, because this is generally not a clinical, not a patient complaints. This is generally an incidental finding on radiographies. So this is renal cell carcinoma is also known as Gravitz tumor or internist tumor or radiologist tumor. Why do we call it as a radiologist tumor? Because this is usually an incidental finding and the radiologist detected. So this is also known as radiologist tumor. So the too late triad is generally when this is not an incidental finding and the patient comes to you with complaints. This is in the last stages generally. So this is known as a too late triad. As we have seen in our case, there is mass, there is pain, and hematuria is also seen. This is the too late triad. And this triad is similar to what? A triad in the Wilms tumor. In Wilms tumor, what do we have? We have two components same and only one component is different. So the two common are mass and hematuria are common in the both the conditions, whereas in Wilms tumor we don't have this pain. We have what? We have fever. Yeah, so we have fever in the Wilms tumor. So you need to remember these triads as well, and also the chromosome number and the other names for the renal cell carcinoma. Okay, hopefully everything is clear. Just let me know if there is any doubt for you. Yeah, and there are histological types in the renal cell carcinoma. What are they? We have a clear cell variant and a chromophobe variant. We also have variants like Bellini variant, which is nothing but it arises from the collecting ducts. These are from the proximal ducts. Okay, this clear cell variant is mostly associated with this VHL, as we have discussed already, and it has a very good prognosis compared to all the other types. Okay, so let's go with the next. So what is the investigation of choice? As we have already discussed, the investigation of choice is a triple phase CECT. A triple phase CECT is the investigation of choice for this renal cell carcinoma. And staging, sometimes wherever you find these named stagings and all, you have to remember it at any cost. So the commonly used staging is TNM staging, as we all of us know: tumor, nodes and metastasis. But the staging which are named ones are Robson's staging. This you need to remember, Robson's staging. And also there's a grading, named grading, that is Fuhrman's grading. Robson's staging and Fuhrman's grading, these both you need to remember. There's also a similar name called Glisson's score. Glisson's score is for CA prostate. Okay, Glisson's is for prostate, and Robson's and Fuhrman's are for renal cell carcinoma. Okay, what is this TNM staging? TNM staging is that is a larger one. You need not remember it exactly, but roughly you can remember it as, this is the kidney, right? Okay, this forgive me for the bad drawing. So this renal cell carcinoma, if it is less than 7 centimeters and it is confined only to the kidney, then this is grade 1 tumor. If it is more than 7 centimeters but it is also confined to the kidney, it is not extending outside, it is not invading the vena cava and all, then this is grade 2. Grade 3 is what? Grade 3, you have an suprarenal gland, right? If the tumor is involving the suprarenal gland, or you have this IVC and renal vein, if this is involving the IVC, this is known as, like here, this is grade 3 renal cell carcinoma. And you have a fascia around the kidney. You have this fascia around the kidney, which is nothing but the Gerota's fascia. Gerota's fascia. This is also an important because this has a different name, no? They ask this usually. So if this is involving the Gerota's fascia and extending outside, this is a grade 4 tumor. This is a grade 4 tumor. So what is the treatment for this renal cell carcinoma? This treatment is generally nephrectomy is done. Radical nephrectomy used to done in those days. In the older days, they used to remove all that part of the kidney. But now they're doing a nephron sparing nephrectomy. Nephron sparing means they preserve most of the nephrons, like functional nephrons are all preserved and the remaining part is removed. So nephron sparing nephrectomy is done. And if not for nephrectomy, if it is an unresectable tumor, then we can go for what? We can go for drugs, medical treatment like chemotherapy with tyrosine kinase inhibitors. Tyrosine kinase inhibitors, this is also an important question. The tyrosine kinase inhibitor used for renal cell carcinoma is sunitinib. Okay, you need to remember this, sunitinib. Okay, let me change the color of the pen so that it will be easier for you. Yeah. So sunitinib is the tyrosine kinase inhibitor we use for renal cell carcinoma. We also use this as a second line drug for what? GIST and other conditions. For that we use sunitinib as a second line option. Okay. Yeah, so this is the picture of the cannon-ball metastasis which I have already mentioned to you. See, these large opacifications. These are the cannon-ball metastasis. Okay, is everything clear with you? Let me check once again. Okay, yeah. So let's proceed with the next question. Okay. Yeah, so the second question is, a 4-year-old child comes to the OPD with the complaints of crying. So age of the patient is also important. So let us see. This is a 4-year-old child comes to the OPD with the complaints of what? Crying. He's crying while urinating. So this indicates he's having either a burning micturition or there is any other complaint, like, yeah, he has given no passing blood clots. So this is what he's saying. The child is having hematuria. He's passing blood in urine. So this is also indicates generally a renal condition or any injury near that. So he's having hematuria. History of fever is present. History of fever. No history of vomitings and nausea. There are no vomitings, there's no nausea. On examination, a mass is palpable. So he has given us mass. He has given us hematuria and also what? Fever. So as we have already seen this as a classical triad for what? For Wilms tumor. This is a classical triad for Wilms tumor, but let us check this again. In the right lumbar region, which is not crossing the midline. Not crossing the midline indicates what? That it is a renal mass. Usually these kidney masses, no, this doesn't cross the midline. This kidney masses usually doesn't cross the midline. Yeah. So CT scan shows a solid mass with cystic areas. Solid mass with cystic areas. This usually indicates his malignancies. They have this cystic hemorrhage and all in the center, no, arising from the right kidney. So what is the most probable diagnosis? As we have already come to the diagnosis, mass, hematuria, fever, which is Wilms tumor, and also see the age also indicates that it is a Wilms tumor. Wilms tumor is commonly seen in the age group of 2 to 4 years. This is seen in small children, 2 to 4 years. Wilms is 4 letters, no, you remember it as 4-year-old child. Yeah. So what are the other features which are pointing out towards this diagnosis? This is a cystic area is present and also it is not crossing the midline. So for suppose let's see the first option. If it is a neuroblastoma, what? Neuroblastoma crosses the midline. It usually this is the most common abdominal childhood malignancy. Most common childhood malignancy is what? Neuroblastoma. But if at all he is asking in the question, see, be careful with the question, read the question twice if possible, if for a shorter question. If he is asking the most common renal childhood malignancy, see, childhood malignancy most common is neuroblastoma. But if he is mentioning this word renal, then the answer goes to Wilms tumor. So then it goes to the Wilms tumor. So our answer is what? Wilms tumor. So let us just see the other options, which is Gravitz tumor. Gravitz tumor is what? As I have already told you, it is nothing but the renal cell carcinoma. What is the fourth option? Rhabdosarcoma. Rhabdosarcoma is no way related to this, no? So the answer is Wilms tumor. Okay. Now let's go to the next question. So I hope this is clear to everyone. Yeah. So, yeah, the third question is, a 38-year-old male comes with the complaints of severe pain in the scrotal region. So, what is the complaint? Severe pain in the scrotal region. Okay, severe pain indicates most probably it is an infective etiology or an infectious etiology. I mean, infectious or an inflammatory etiology. So, history of high-grade fever is present. This also points out towards an infectious condition. On examination, what did he give? There is blackish discoloration of the perineum. If he is mentioning this blackish discoloration of perineum, probably this is pointing out towards what? Gangrenous condition. Yeah. So seen with fetid odor, foul smelling. Foul smelling is also present, and watery discharge. So what is this condition? His total leukocyte counts are 18,000, which is indicating that the patient is in sepsis, indicating that it is a rapidly spreading or a serious condition. So what is the treatment you would advise for this patient? First, you need to know the diagnosis if you want to answer the treatment. So what is the diagnosis in this condition? He has given pain in the scrotal region, discoloration, which is gangrene, and also foul smelling. So this is the polymicrobial infection, which is nothing but our classic Fournier's gangrene. So this is classically pointing out towards Fournier's gangrene. If you have seen this case once in your life, you won't forget, because it will have that much foul smell that you won't forget again. So the diagnosis is Fournier's gangrene. So what do you need to know about Fournier's gangrene? This Fournier's gangrene is nothing but gangrene or the necrotizing fasciitis of what? Scrotal skin. Just it involves only the skin, superficial fascia and the deep fascia. It involves only these three conditions. It doesn't involve the testis. The testis is spared, corpora spongiosum, corpora cavernosa, all these are spared in Fournier's gangrene. These are not involved. Only these three are involved. So this is a polymicrobial. So you need to put on higher antibiotics, like wide coverage antibiotics. So what is the treatment you would advise? Let us see the options. Option A, antibiotics only. See this only word, no? If it is present in an answer, mostly try to eliminate it as an answer. If we put him on only antibiotics, will the condition become normal? No, because there is a septic foci going on which has already underwent necrosis. So you have to remove that septic foci for the patient to become stable. So antibiotics only is not the answer. Next, bilateral orchidectomy. Bilateral orchidectomy is nothing but removal of your testis. So as I already told you, testis is spared in this condition. It is not involved. The testis are viable. So why would you remove a viable testis? So bilateral orchidectomy is also not the option. So let us go with the third option. Daily dressings and unilateral orchidectomy. So you would not be doing orchidectomy anyways, and only dressings will not be sufficient as it is already underwent necrosis. So this is also not the option. So what is the fourth option? Extensive skin debridement and skin grafting. So as the foci is here in the skin only, you have to debride all of that skin, leaving a fresh margin until it bleeds freshly. So you will do an extensive skin debridement plus skin grafting. As you are removing all the three layers of the you are removing the skin, superficial fascia and all, you need to do a grafting there. So this is our answer for the Fournier's gangrene. So option 4 is the answer. I hope it's clear to everyone. Let me check if there is any doubt for you. Okay. Yeah, so shall we proceed to the next question? Okay. So the next question is, all of the following are included in the Sipple syndrome except. What is the Sipple syndrome? First you need to know what is this. Sipple syndrome is nothing but your Sipple syndrome is nothing but your men 2A. Okay, so this men syndromes are very much important for your exams. So men syndromes are men 1 and men 2. Men 1 and men 2. Men 2 is again we have this men 2A and men 2B. So the first men 1 is associated with what? 1 is associated with chromosome number 2. You need to remember these chromosomes as well. 1 is associated with chromosome number 2 and men 2 is associated with what? Chromosome number 10. 1 as 2, 2 as 10. Just remember like that. So you need to know the other names for these conditions, so that if he give the question as like the Sipple syndrome or Werner's syndrome, you need to know the other names.
So what is this MEN1? MEN1 is also known as Wermer's syndrome. Wermer's syndrome. MEN2A is known as our question, the Sipple syndrome. What is meant to be known as? Meant to be is known as Garland's syndrome. Usually they'll be asking you about MEN1 or MEN2A, like the other names. And MEN1 is associated with a gene known as menin gene. How do you remember this menin in? I know this one as MEN1. So MEN2 is associated with what? This is associated with the red proto-oncogene. Red proto-oncogene. So you know the chromosome numbers, you know the genes associated, you know the other names as well. So what else do you need to know? You need to know the components of the men's syndrome. He's asking the same, no? He's asking the components. So what are the options? Parathyroid hypoplasia, megacolon, pheochromocytoma and marfanoid habitus. So I'll give you a mnemonic, need not worry, you can remember it easily, okay? So for MEN1, let's see for MEN1. Okay, first I'll tell you a story, okay? Yeah. So remember it as Papa makes pies on pan. Who is he making for? He's making for his daughter Phoebe. So he made pies on pan and he met Phoebe. So Papa makes pies on pan is for MEN1. For MEN2A, this is Papa met Phoebe. So MEN2B is also known as MEN3. Okay, MEN2B and MEN3 are same. So for MEN3, what? After seeing all this, it made Phoebe melt. So this is the mnemonic you need to remember. Just remember it when you're like sitting leisurely, you recollect it once or twice and it will become easy for you. So what is this Papa for? This PA is for parathyroid. Okay, let me change the color, just a minute. Yeah, so PA in this in this Papa is for parathyroid hypoplasia. So next, what? This makes you forget this. You leave this. And this PI is what? PI is pituitary adenoma. And this PAN. Yeah, and this PAN is for pancreatic neuroendocrine tumor. Just remember it as pancreatic tumor. PAN is there, no? Pancreatic. So PA is for parathyroid hypoplasia, PI is for pituitary adenoma and PAN is for pancreatic tumor. So these three are the components for the MEN1. So what is MEN2A? MEN2A is what? Yeah, our Sipple syndrome. So what is the mnemonic for this? Papa met Phoebe. So as usual, this PA, Papa, is for parathyroid hypoplasia. The same continuation of this. This MET is for medullary thyroid carcinoma. And this ME is again another component is also there, that is megacolon. So megacolon and medullary thyroid carcinoma, this both comes under MEN2A. So what is the other component? It is Phi for pheochromocytoma. Okay, Phi is for pheochromocytoma. So parathyroid hypoplasia, medullary thyroid carcinoma, megacolon and pheochromocytoma. These are the components of our Sipple syndrome. Okay, let's see the MEN2B or the MEN3. What does this include? Made Phoebe melt. This made Phoebe. Phoebe is the same, no? Pheochromocytoma. You can carry on with this. And melt is also same like this ME. medullary thyroid carcinoma and megacolon. So what is the only component that is new in this? This is MA. MA is for marfanoid habitus, like marfanoid facies and all. That comes under our MEN 3. And one, okay, let me tell you an extra point here. What do we need to remember in Marfan syndrome is, Marfan syndrome, there is ectopia lentis. Okay, he'll be frequently asking this question as well. Ectopia lentis. So let's see through our question. So he's asking the components of the Sipple syndrome. So first we need to remember the mnemonic of the Sipple syndrome. What is the mnemonic for the Sipple syndrome? This is the second one, no? So first one is Papa made pies on pan, and the second one is Papa met Phoebe. Okay, so this Papa is for parathyroid hypoplasia. So we have that in the option. This is correct. And we have what? Medullary thyroid carcinoma and megacolon. Megacolon we have, so this is also in Sipple's. And what is the third one? We have pheochromocytoma. So we have this in our options as well. So what is left? Marfanoid habitus. The only new thing in our meant to be. Yeah, exactly. Or our MEN 3. So this is our answer. So I hope this is easy for you all. Just see the mnemonic once again. Yeah, just go through the mnemonic once again, everyone. Okay, let's proceed to our next question. Yeah, the following is the X-ray of a 5-year-old who swallowed a coin. So this X-ray questions, this coin questions almost comes every alternate year. Okay, so let's go through this. X-ray of a 5-year-old who swallowed a coin. He's asking about what? He's asking the true statement. The true statement is, what is he saying? Lateral view showing linear opacity indicating coin in trachea. So first of all, what is this? This is the coin, and it is how it is showing. It is a circular opacity in the X-ray. Lateral view showing linear opacity. This is the lateral view, fine. Lateral view showing circular opacity. What did he give? Lateral showing linear opacity, which is, you can eliminate this option here itself. So it's wrong. Next option, frontal view shows linear opacity. He's not saying that this is a frontal view. He's saying frontal view shows. So you need to be good with these English sentences as well now. Frontal view. So this is the lateral view. If at all it is in the frontal view, what will it show? First, let me tell you how a coin looks in a frontal view and lateral view when it is in esophagus or trachea. Okay, first let us go through the next. Yeah. So just remember that to enter the trachea, this is trachea for suppose. To enter the trachea, what do we have? We have the vocal cords here, right? So to pass through the trachea, through the vocal cords, we need the coin to be in a straight line. Only when if it is in this condition only it will pass, no, between this. So in a frontal view, how will you see if it is in trachea? You will see it is a frontal view, linear opacity, trachea. Or remember it as linear opacity in the frontal view is indicates it's in trachea, LFT. This is one mnemonic you can remember, or you can remember this vocal cords. You can remember it in either ways. Linear opacity in frontal view indicates it's in trachea. Yeah. So if it is in esophagus, for esophagus we don't have any cords, so it can enter directly. So the coin is seen as circular opacity. So circular opacity in frontal view indicates it's in esophagus. So you can remember this. Through this you can see the other options. So LFT. So where are we matching with the LFT? This is L, this is L. No, not matching, no. So here it is frontal view, linear opacity, and esophagus. This is also not matching. You can eliminate this option as well. So the third option here, frontal view, linear opacity indicating coin in trachea. So we got our LFT. So this is the answer if you want to go through the mnemonics, or if you want to go logically, then you can remember this vocal cords and then you can attempt it. So also let us check the fourth option. Lateral view showing circular opacity indicating it is an esophagus. Lateral circular esophagus. This is also not matching. So the answer is option C. Yes. Yeah. So let us go to the next question, which is a 16-year-old comes with the complaints of swelling in the midline of neck since 2 years. Swelling in the midline of the neck since 2 years. No compression symptoms. No compression symptoms indicates it is not a larger mass and it is not compressing or encroaching. It is not a malignancy probably. So, and pain, no fever, no pain. It is not also an infectious condition. It is not also a malignancy. What is it now? On examination, the swelling moves with deglutition. Here is our clue to the question. It moves with deglutition and also with protrusion of tongue. In this thyroid swellings, we need to know two things. If the swelling is moving only with deglutition or both with deglutition and protrusion. So, if it is moving only with deglutition, it is a thyroid swelling. If it is moving both with deglutition and tongue protrusion also, then it is what? A thyroglossal cyst probably. Okay, here is the direct hint, but let's also see the explanation so that you'll understand. What is a thyroglossal cyst? We have a tongue, right? We have our foramen cecum here. So from the foramen cecum, a duct arises. This duct enlarges and gives our thyroid gland, the so-called the butterfly shaped gland. After giving this thyroid gland, this duct disappears. If at all it is persistent, no, here we have a hyoid. If at all it is persistent, then it may give rise to thyroglossal cyst. It may give rise to thyroglossal cyst. So this thyroglossal cyst is nothing but the remnant of the thyroglossal duct which is arising from the foramen cecum. So there is a connection from the tongue, no? So it also moves with tongue protrusion. That gives our clue that it is a thyroglossal cyst. So let's see the options. Our first option only is our answer. So this is the answer. Let's see the other options. Nodular goiter. We can rule out nodular goiter, which is thyroid, as it is moving with protrusion of tongue. Thyroid is, after this remnant has gone, it has no connection with the tongue, no? So it doesn't move with tongue protrusion. So we can rule out thyroid. Next, branchial cyst. Branchial cyst is mostly a congenital, whereas this thyroglossal cyst is never a congenital condition. This is never congenital. So he is presenting at 16 years. If it is from birth itself, they would have come earlier only, no? So this also you can eliminate it. And ranula. Ranula is what? Ranula is when you lift up your tongue, you have this posterior aspect, no? Here one transparent bluish colored cystic lesion comes. That is ranula. So that is also not related to this. So our answer is thyroglossal cyst. Yeah. So let's proceed to the next question. I hope everything is clear. Yeah. And also let us see these as well. Most common site is what? Most common site is retrohyoid for a thyroglossal cyst. Why is this? Because it is passing behind the hyoid bone, no? Here it might, remnant might become it might be remnant there. So it is retrohyoid is the most common site. Diagnosis is by you have to do an FNAC of the swelling. Treatment is you have to excise this cyst, this whole tract and this part of the hyoid bone as well. All this together is known as cyst trunks procedure. You need to remember the named procedures as well. They'll ask these in questions also. So cyst trunk procedure. Yeah. And you should not do an incision and drainage in the thyroglossal cyst, because when you're draining the cyst, you're giving a way for a fistula formation. So there is a risk of fistula if you do an IND. So you shouldn't do IND in a thyroglossal cyst. Okay, let's go with the next question now. The correct combination from the below statements. What is he asking? Again, correct, not the false ones.
And there's no except as well. Okay, let's check that again. So the first option is Omphalocele is sackless, whereas gastroschisis has a sac. So this omphalocele and gastroschisis are two important conditions where you'll have one question every often. So let's see the pictures first. Whenever they say these words, you have to remember this picture exactly in your mind. So this omphalocele is O, no? You remember this O-shaped sac. So this O is for sac. So omphalocele has a sac, whereas gastroschisis, these are the intestines. This doesn't have any sac. So omphalocele, O in our omphalocele is for what? Sac. So here he gave it as omphalocele is sackless. But what did we see? Omphalocele has a sac. So this is wrong statement. And this is gastroschisis has a sac, it doesn't have. So this is also a wrong statement. So this is eliminated. So let's go to the next option. Defect in omphalocele is to the right side of the umbilicus. Defect is to the right side of the umbilicus, he's saying, in omphalocele. So let's see the picture again. So here, the omphalocele, this is what? This is physiological herniation which failed to go inside. So physiologically, while the baby is undergoing development, these bowel loops herniate outside and they go in again. But here, if they fail to go out, so where are they herniating from? They are herniating from the umbilicus. So this is a midline. This is a midline swelling. Whereas in gastroschisis, you can see a separate umbilical cord here and the contents are separate. So this is not in the midline. Umbilical cord is in the midline, right? So most commonly we see it towards the right side of the umbilical cord. So let's see the option in the question. Defect in omphalocele is to the right side of the umbilicus. But where did we see in the omphalocele? This is through the umbilicus. So omphalocele is through umbilicus. So this is also a wrong option. And gastroschisis, it is not in the midline. It's to the right side of the cord. So this is also a wrong option. So now option C. Omphalocele may include liver as content, unlike gastroschisis. Omphalocele, what are the contents of these two? See, here, as I already told, this is the physiological herniation of the bowel loops. So we don't see any liver here. But this is just the contents are herniating out. So here most commonly we see liver herniating. Bowel loops can also be seen. Liver is also seen. Liver is the most common content in gastroschisis. Remember that, don't forget. Just you have to remember that this omphalocele is a physiological herniation of the bowel loops only. Okay. So omphalocele doesn't include liver as content. This is also eliminated. So let's see the remaining option. Omphalocele is most directly associated with other congenital anomalies, unlike gastroschisis. Even if you don't know the statements also, through that picture you can eliminate all these three. So the answer is option D. But just remember this, that omphalocele is associated with congenital anomalies. But gastroschisis, it is not associated with any congenital anomalies. Okay. Okay, moving on forward. Let's go to the next question. Question number 8. So what is this? A 24-year-old male present to you with a 4-day history of pain in the right iliac fossa. See, he's having a 4-day history of pain. Where? In the right iliac fossa. What does it strike whenever you say about right iliac fossa? Obviously your appendix. So history of 3 episodes of vomitings per day 2 days ago. Not now. He's having vomitings history 2 days ago. Okay, fine. Vomitings. You can also see this in appendicitis. So it might be an appendicitis. History of fever. Fever is also seen in appendicitis. So till now our diagnosis is appendicitis. On examination, mild tenderness present at the McBurney's point. So this is also pointing out towards what? Appendicitis. And a tympanic mass is felt. Generally in appendicitis we don't feel the mass. But whenever he's saying this tympanic mass is felt, and he's also talking about 4-day history. Generally appendicitis before like less than 72 hours, after 72 hours is considered differently. Less than 72 hours you go for operative and it is considered as appendicitis only. But after 72 hours, like after 3 days, it is considered as it might like go into an appendicular mass. So as he also is giving that mass is felt, this most probably point out towards appendicular mass. So what is he asking? All are true except, again this except. He's asking true except. So what is he asking? He's asking the false statement here. Okay, let's see the options. Option A, contents include appendix, greater omentum, small bowel and cecum. What is this appendicular mass? Why is this mass forming? This inflamed appendix, when it is like undergoing a 4-day transformation, it includes the surrounding areas. The inflammation spreads to the surrounding areas and that all of that is contained and forms a mass-like structure. It includes appendix, greater omentum, small bowel and cecum. These are the contents of the appendicular mass. You need to know this. These are the contents of the appendicular mass. So this is a true statement, but he's asking what a false statement. So let's see the next option. Ochsner-Sharon regime is the conservative management. The other option is Biscard regimen is the conservative management. So he has given two regimens. One is Ochsner-Sharon and one is Biscard. So you need to know these named regimens as well. These are very important, both of these. So where do we use this Biscard regimen? This Biscard regimen, we use it in a venous ulcer. Venous ulcers like we see in varicose veins and all, no, that venous ulcer we use this Biscard regimen. What is this regimen including of? It includes massage, limb elevation. This is not writing properly, pardon me for that. Okay, this includes massage. This includes massage, limb elevation and compression stockings, so that the venous blood is not pulled up and it doesn't like go stasis there. This is the Biscard regimen for venous ulcer. What is this Ochsner-Sharon regime? Ochsner-Sharon regime is the named regimen you need to remember for appendicitis. You need to remember this definitely for appendicular mass, not appendicitis. Appendicular mass, sorry for that. Yeah, so what is this Ochsner-Sharon regime? You put an appendicitis patient on nil per oral. So same for the appendicular mass. This is a conservative management. You are not undertaking any surgery here. So the Ochsner-Sharon regime includes nil per oral. You are putting the patient on NBM. You are not giving any oral intake. So nil per oral, and you put him on antibiotics. Nil per oral, antibiotics, and you monitor the mass size. This is mass, no? If it is spreading to other organs as well. The mass size you'll monitor regularly, and temperature you'll monitor every 2 hours. Vitals are monitored every 2 hours and the mass size is monitored. This is known as Ochsner-Sharon regime. Okay, so this is the management for appendicular mass. So this is also true. Biscard regimen is the conservative management for what? For venous ulcer, not for this. So this is our false option. So this is the answer. And fourth one, what? Mantral scoring is used to predict acute appendicitis. Mantral scoring, and we need to also remember this named scoring systems as well. Mantral scoring and others like Robson staging, Furman's grading. I told no, these named scorings and all you need to remember. Ranson scoring for pancreatitis. All these you need to remember. So Mantrals is for what? Mantral scoring is used to predict acute appendicitis. In appendicitis patients, we'll see this Mantral scoring. This is true. Mantrals is what you need to remember this. Okay, yeah. Mantral scoring is M is for migratory pain. Migratory pain. In appendicitis, where do we have this pain migrating from the umbilicus to the right iliac fossa? No, this is the migratory pain in the appendicitis. And A is for anorexia. The patient feels weak and doesn't feel like eating. That is anorexia. And N is for nausea and vomiting. As in this condition, the patient had vomiting. So if the case came to you 2 days ago and you're assessing the appendicitis condition. So N is for nausea and vomitings. So Mantrals, M is for migratory pain, A is for anorexia, and N is for nausea, vomiting.
Next T. T is for tenderness. Tenderness in the right iliac fossa. As in our question there, it had tenderness in the McBurney's point. McBurney's point is nothing but the midpoint from the umbilicus to the anterior superior iliac spine. We have our anterior superior iliac spine and we have our umbilicus. So we'll take a midpoint from that. Here it is the McBurney's point. Like 2/3 and 1/3. 2/3 from the umbilicus, 1/3 from the anterior superior iliac spine. So that is the McBurney's point. This tenderness is also considered in the scoring. Next we have our R. R is what? Migratory pain, anorexia, nausea, vomiting, tenderness, and mandrels. R and E. E is for elevated temperature. E is for what? Elevated temperature. And L. L is for leukocytosis. You have this leukocytosis. No, you'll send your blood investigations and all. In that you'll see the WBC count and see that leukocytosis is present or not. These all have a scoring of 1-1 and some are having scoring of 2. That you need not remember. For now, you need to remember just the components of the scoring system. And S. S is shift to left. You'll see that if it is on an increasing end or on the decreasing end. So these components you need to remember. That is the mantle scoring. That if it is like less than 6 and all, it indicates like this is a definitive diagnosis or it is a probable diagnosis, like that. Just you need to remember the scoring system. This is for what? Next, like similar scoring systems. Ransons. Ransons is for your pancreatitis. Mandrels is for appendicitis. Ransons is for pancreatitis. Okay. Yeah, this, sorry, I didn't say this R, no? This T is for temperature and R is for radiating tenderness and pain. Okay, let's go to the next slide. What is the next question? The next question is a 46-year-old female underwent lap cholecystectomy. What did he go? Underwent a lap cholecystectomy. Cholecystectomy is, as you know, it is a removal of the gallbladder. So underwent it 3 days ago and now has complaints of fever and tachycardia. He's having complaints of what? Fever and also tachycardia. Total leukocyte count is 15,000. 15,000 indicates there's an infection going on. And on doing an ultrasound abdomen, there is a collection of 5/6 centimeters noted in the right hypochondrium. So what is this condition he's talking about? What is the most common complication of the lap cholecystectomy you see in after 72 hours? Like 48 to 72 hours. The most common complication is a bile leak. You're working on the gallbladder, no? So there might be a bile leak. Just ignore the pen is not working properly. So bile leak is the most common complication of the cholecystectomy, post-cholecystectomy patients. So yeah, this is what he's talking about. See, lap cholecystectomy, 3 days history, fever, tachycardia. This bile is an irritant, no? So it causes tachycardia and fever. Also the counts are increased, indicating the bile presence. Also he gave the collection of 5/6 noted. So that is the bile collection there in the right hypochondrium. So what is the next best step? So for this, in bile leak conditions, you'll do 2 things. If it is before 3 days, like before 72 hours of the surgery, then you'll what will you do? You'll go re-explorate the, like you'll again operate on the patient and re-explorate it. But if it is after presenting to you after 72 hours, like after 3 days, he said no, complaints of 3 days ago. So after 72 hours, then what will you do? The collection of the bile has to come out, right? So you place a pigtail catheter. You place what? You place a pigtail catheter. This is important. You need to also remember the picture of the pigtail catheter. Sometimes the pictographs are also asked in that. So just see a pigtail catheter. This is the picture of a pigtail catheter. So this is a pigtail catheter. Just remember the picture. So the answer is what? Our USG guided pigtail catheter. So let's go with the next question. A 48-year-old male, a case of varicose veins since the last 3 years, presented with findings as shown below. He also had an ulcer 4 months ago which healed a month ago. So he's having an ulcer which has healed and now has another fresh ulcer. So he's now having what? He's having an active ulcer. How do you classify this patient as per CEAP classification? The CEAP, you need to remember, in this the C is important for you. Questions will be coming from this part only. So what does the C indicate? Clinical classification. So in this clinical classification we have C0, 1, 2, 3, 4, 5, 6. But the 0 is what? 0 means nothing. So no visible or palpable signs of the disease. C1 is C1, smaller ones. We have telangiectasias or reticular veins. 1, no, less than 1 centimeters are considered as reticular veins. C2, varicose veins. Varicose veins are considered only when they are above 3 centimeters, like 3 mm, sorry. So less than 1 mm reticular veins, more than 3 mm varicose veins. Less than 1 is telangiectasia, 2 to 3. In between are these reticular veins, and more than 3 mm is your varicose veins. So if there are visible varicose veins, then you classify it as C2. C3 is edema. C4, you have C4A and B. First, what does this happen? The pigments are deposited there and pigmentation occurs. After that, the skin hardening occurs. So pigmentation is 4A and lipodermatosclerosis or the atrophia blancae is C4B. You need to remember this classification at any cost. Just remember it as first smaller veins are coming which are enlarging, varicose veins, then edema is coming due to the fluid accumulation, and then the accumulated pigments cause pigmentation and the skin is thickened. You remember it in that order so that it will be easier for you. What is C5? These two are important again. C5 is a healed venous ulcer. C6 is an active venous ulcer. Remember the rest of the things you need not remember. You remember from C0 to C6. And in this also mainly you have to remember reticular and varicose veins diameter differences, this pigmentation 4A, 4B, and difference for this 5 and 6. So let's go to our question. But what is he giving here? He gave us these smaller veins. These are what? Telangiectasias, looking like less than 1 mm, no? Telangiectasias. 2 to 3 mm is our reticular veins. Greater than 3 are our varicose veins. So here he gave telangiectasias. According to this, how we'll classify C1. But he also gave that he has a healed ulcer is present. So for that we'll take the classification as C5. But he's also telling that he has an active ulcer. So where is our active ulcer? It is active venous ulcer is C6. So of this, what do you say the answer as? You should remember this. You should always take the higher class as your answer. So the C6 higher grade is considered. So C6 is the condition of the patient. You classify the patient as C6. So just remember this table once again, recollect it later. Let's proceed to the next question. A boy who underwent an accident and had a straddle injury. Straddle injury means like while he's sitting on any horse or on bicycle. Yeah, straddle injury. Presented to ER with blood at the tip of the meatus. So what is he saying? There is blood at the tip of the meatus. Tip of the meatus means it is indicating a urethral injury probably. So he has not passed urine since then. So the urine is not coming out. If there are any blood clots or something here, urethral injury is present. So the pull-up of the urine takes place in the bladder. So what do we do on ultrasound? But the bladder is showing it's empty. Maybe he has not taken anything or something. So bladder is empty. What is the next best step of management? He's not asking the best step. He's asking the next best step. Generally what do you do for this urethral injuries? You have your bladder here, right? You do a suprapubic cystostomy. You place your catheter drain. You put a hole in the bladder and put a suprapubic drain. So suprapubic cystostomy. Ostomy means up hole placement. So this is done. But for that, always remember the prerequisite for a suprapubic cystostomy should be a full bladder. For this, it should be a full bladder.
So, but he's telling that the bladder is empty. So you shouldn't directly go for a suprapubic cystostomy. So this is not our option. Foley's catheterization. You should never put a Foley's catheter if there is blood at meatus. It is indicating there's already urethral injury. Why do you want to put it again and increase the injury? So this is also not an option, because he's asking the best option, no? So what is the option C? Wait for the bladder to fill and then do the SPC. So this is exactly what we have discussed. We'll wait for the bladder to fill all that water, like take fluids and all. We'll wait for the bladder to fill and then put a suprapubic tube. Suprapubic cystostomy is done. So this is our answer. So let's go to the next question. I hope this is clear for you all. Yeah, question number 12. So this is the last question for today's session. We'll be discussing the rest 13 questions in the next session, which is on 7th February. Okay, let's discuss the last question for today. I think everyone's exhausted now as well. So 12th question. A female presented with complaints of swelling in front of neck since 10 years. 10 years is a very long history for any swelling to be. So he's saying neck swelling. Neck swelling means, what did we think of generally? Thyroid swelling or a TGC, thyroglossal cyst. So thyroid swelling, moving only with deglutition. This is confirming that it is our thyroid swelling. So on examination, the surface is nodular surface. Okay. Patient has no signs and symptoms of hypo or hypothyroidism. This indicates what? The patient is in a euthyroid state. For any surgery to be performed, the patient should come into a euthyroid state. So what did he give? He gave the history of loss of weight and appetite. As we already discussed, these indicates that it is a malignant transformation usually. Also has hoarseness of voice and dysphagia. What is this hoarseness of voice and dysphagia? This is indicating that it is compressing the trachea and the esophagus. The mass is compressing the esophagus and trachea. So probably this is a malignant lesion, as it also has a long history. So what is this generally like indicating? First, the patient might had a multinodular goiter which has underwent a malignant transformation and formed a malignant thyroid goiter, which is nothing but MNG. You need to diagnose this first, because he has given a nodular swelling moving only with deglutition. So probably a multinodular goiter. So this multinodular goiter has a chance of which malignancy is it more prone for? You need to remember this. Which malignancy is more which conditions are more prone for papillary carcinoma of thyroid, which are more prone for follicular carcinoma. So malignant nodular goiter is more prone to undergo a transformation and form follicular thyroid carcinoma, not a papillary. As we discussed earlier, the thyroglossal cyst has a predisposition for papillary thyroid carcinoma, but our multinodular goiter, it has a predisposition to undergo transform into follicular thyroid carcinoma. Okay, so let's see the options. What did he ask? All are true except. Again, except. So he's asking the false statement. What is the false statement? First option is orphan nuclei are seen on histology. Where do we see this orphan nuclei? You need to remember this histology slides. You need to be familiar with these histology slides, some named like cells. See, this is our orphan Annie. This is a cartoon character from which they have named these similar cells. So these cells look like this, eyes of this Annie. So they have named it as orphan Annie nuclei. So these orphan Annie nuclei, you need to remember this slide. You need to like recognize these. So orphan Annie nuclei are seen on histology. Orphan Annie nuclei are seen on papillary thyroid carcinoma and not on follicular. Okay, for this, first let me tell you what is a follicular. How do you identify a follicular and papillary? So for thyroid, you have a papillary thyroid carcinoma and follicular thyroid carcinoma and a anaplastic carcinoma, and in between you have a variant of this follicular known as Urethral cell carcinoma. These three are differentiated tumors, and this anaplastic is undifferentiated. Okay. First let us see about this papillary thyroid carcinoma. Papillary thyroid carcinoma, just remember that this also as papa and a daughter's relation. So papillary thyroid carcinoma is commonly seen. Papa loves his daughters, right? So it is commonly seen in whom? Females more than males. So seen in commonly in females. Okay, let us suppose for this daughter's name is Annie. So this orphan Annie nuclei are seen in what? This papillary carcinoma. So you can remember it easily like this. Papa, females, or Annie. Annie is her name. So this is a best relation, no? Father and daughter. So obviously this has the best prognosis. Best prognosis. Okay, for follicular thyroid carcinoma, and this papillary is commonly seen in whom? This is commonly seen in radiation exposure patients. Radiation exposure, BRAF mutations. These all you need not remember. And one more important point is papillary, P. P is for psammoma bodies. Psammoma bodies. Psammoma bodies are nothing but what? These onion ring like structures, this pinkish structures, these are the psammoma bodies. Where do you see these psammoma bodies? This is also another very, very important question. You can star mark it as many times as you want. So the psammoma bodies are seen in, you can remember it as PSM. So papillary thyroid carcinoma, papillary renal carcinoma, both of this you can see this psammoma bodies. And S is for what? Serous cystadenoma of ovary. Serous cystadenoma of the ovary. And this M is for meningioma. Meningioma. All these conditions you see these psammoma bodies. He can give us these psammoma bodies are seen in all of the conditions except. He can give it like that, no? So that is one question. So let's continue further. So these all you need to remember for papillary thyroid carcinoma. And follicular thyroid carcinoma, what do you need to remember for these? These are common in iodine deficiency areas. Like you have these endemic areas where there is iodine deficiency, you know. In those areas, this follicular carcinoma is common. This is seen in follicular deficiency areas. And the risk factor for this is multinodular goiter. Multinodular goiter, if it is long standing, this might transform into follicular thyroid carcinoma. And one more point you need to remember is FNAC is not the diagnosis of not the diagnostic procedure of choice, because FNAC can't differentiate between a follicular adenoma and a follicular carcinoma. It can't differentiate the two conditions. So FNAC is not usually done for a follicular thyroid carcinoma, like when you are suspecting this. So FNAC is not the investigation of choice. And one more thing, as I already told you, we see osteolytic bony mets here. Osteolytic bony mets. And also, these metastases are pulsatile metastases. The same these are seen in renal cell carcinoma, as we already discussed. So these are the points you need to remember for follicular thyroid carcinoma. And Urethral cell carcinoma, he'll just give these Urethral cells, which are nothing but these cells with cytoplasm, abundant cytoplasm, prominent nuclei, and this clear round central nuclei are there. No? These are the Urethral cells, classic of the Urethral cells. Histology you need to remember for these orphan Annie nuclei, for these psammoma bodies, and also these Urethral cells. So Urethral cells, H for H, are seen in Urethral cell carcinoma. And also another H you need to remember is Hashimoto's. Hashimoto's has a chance for undergoing malignancy to Urethral cell carcinoma. So thyroglossal cyst undergoes papillary carcinoma, predisposes to papillary carcinoma, multinodular goiter to follicular, and Hashimoto's to Urethral cell. Okay, is it clear? And this anaplastic anaplasia, as you know, is an undifferentiated tumor. Undifferentiated. So in this we have this P53 gene mutation and beta catenin mutations. Just remember this. That is enough for this. So I hope everything is clear and you're not having any doubts. And the rest of the 13 questions will be discussed in the next session, which is on 7th February. Okay. If you have any doubts for any questions, you can just check it once again. I hope I've covered most of the important topics which are like often repeated, and people make mistakes in these questions only. So generally, yeah, I've covered almost everything, like the most important questions, and rest I'll be covering in the session on the 7th February. Okay, shall we end this session now? Yeah. Yeah, I hope everyone is exhausted by now. It's already a long session. Yeah, thank you. Don't forget to check on the Medicoz community website and avail this early bird offer which is present there, so that you can start preparing from now itself. No, you can like correlate with your clinicals which are going on in your college with these things. And it will make you like easier either ways. You can do well there as well, and it will make your preparation easy as well. So yeah, done for today. Thank you for all of us for staying this long